Okay, now I'm going to start calling people out. Simple. It's as simple as this. Even if I kick half the class, it's okay. You can go and complain about it. I'm okay with it. Said I'm going to start calling people out. As simple as this. Even if I kick half of the class, it's fine. But funny enough that 170 students failed last semester in Mole 1. And yet, this is the kind of attitude we get. Okay, today is the third and last session of this module, which is enzymology. And it's very important because what we're going to be talking about literally is going to be in every block. You're going to take some diagnostic profiles that you will see in different blocks, GI, musculoskeletal block. Literally, every block, you're going to have some tests that you should know about. So this is just an introduction about these diagnostic tests. Not all of them. We're going to just be talking about enzymes that we will or we utilize to differentially diagnose different diseases. And as I said, we're going to discuss it in more general. Objectives as listed in the slides. Review properties of enzymes, which we already know what enzymes are. Distinguish between tissue distribution of isoenzymes. Now here's my thing. What's the difference between transcript variants that you've been hearing about and isoenzymes? Transcript variants. What's unique about transcript variants? Any idea? When I say transcript variants, what's the difference between transcript variants and isoenzymes? What are isoenzymes in the first place? Isoenzymes, what is?
Are enzymes that carry a certain function but at different rates.
Not certain function. They catalyze the same reaction.
Specific reaction.
Specific reaction. Are they the same?
Different. Rates.
Different. So many things. We're going to discuss these differences. But do they come from the same gene? Isoenzymes. When we talked about hexokinase, glucokinase, are you telling us these are transcript variants? What's the difference between transcript variants and isoenzymes? We know that isoenzymes, they carry the same reaction. Transcript variants, are they the same proteins? They originate from the same gene. Alternative splicing, right?
Yes.
But do they carry the same function? No. So are you telling us isoenzymes, they can come from different genes? Yes. That's the difference between isoenzymes and transcript variants of a gene. So what do we use the isoenzymes for? We're going to look into it because we're going to be talking about several isoenzymes. I already talked to you about hexokinase and glucokinase, but this time I'm going to tell you about isoenzymes and how we could utilize them for diagnosis. So when we say heart attack, someone is having a heart attack and you do measure CKMB. What is CKMB? We're going to discuss this. This is an isoenzyme of CK, but we go for CKMB. Why? Because there's more of it in the heart. So when there's heart attack, it's released into circulation. As a result, we could utilize it to see if the heart has suffered damage. As simple as this. So we will discuss isoenzymes and also their distribution. We're going to discuss also enzyme deficiency, and here we're going to be basically describing the inborn errors of metabolism. Do you know what inborn errors of metabolism are? How many? So far around 500. So these people are born with deficiencies or mutations in enzyme involved in metabolism. And there's so many. Do we screen for it here in Saudi Arabia?
40 of them.
Well, unfortunately, the research center now can screen only 27. You know the rules. 27. So what about the other rest of it? Well, we send it to Germany. And that costs around $500 a sample. But they will tell you most likely what are the inborn, most likely what which enzyme is affected. And these could be fatal, basically. Why? Because there's accumulation of substrate that could damage the tissue. And that's why, if you notice that if a new infant is born, what do? They weigh him at 24 hours to see if he's gaining weight and his metabolism is normal. And then they ask to see him after a few days to see if his metabolism is normal, because he may have inborn error metabolism. That could result into basically to death if this is not taken care of. So we will discuss some of these enzyme deficiencies, at least get a general idea about it. And also we're gonna talk about use of enzymes in routine clinical diagnosis. We're gonna describe what is known as functional and non-functional enzymes. What are functional? If I say there are non-functional enzymes in serum, what do I mean by non-functional enzymes in the serum, in the blood? If I say CK, creatine kinase, creatine phosphokinase, or lactate dehydrogenase, LDH, is this enzyme functional or non-functional in the serum? Non-functional. So why is it present in the serum? Because it's released from the damaged cells. But they have no function in blood versus coagulation enzymes. And this is the difference between functional and non-functional enzymes. So these enzymes that are non-functional would increase in two conditions. One, there's damage to the tissue. Secondly, if there is cancer. So normally, these enzymes, non-functional, are present at low levels in the serum. Low levels. Why? Because there is a turnover of cells. So there is a damage to cells. I mean, cells regenerate. And as a result, there's some leak of these enzymes into circulation, so they're at low level. But if we have cancer, so we have more cells, what happens? There's more enzyme leaking into circulation. So it's not only about damage, releasing these non-functional enzymes into circulation, but also cancer proliferation could lead to release more of this non-functional enzyme into circulation. So we could use it as a diagnostic tool for cancer as well. So we'll discuss this. In general, we'll talk about profiling. When you say, I need the liver function test, you heard about the LFT, liver function test? What is it? To see if the liver is functioning, right? And moreover, can we differentially diagnose what could be the specific cause? In order for us to do this, we have to use what we call profile, multiple analytes. Usually these profiles include a lot of enzymes. That's the whole idea of profiling. Why one? Why more? Well, we use more because of non-specificity. So now I'd like you to know two terms, sensitivity and specificity. When I say this test is sensitive for heart attack, what do I mean by sensitive? It's detecting heart attacks, right? But this is the general lay term of definition. Definition of sensitivity is percentage of people who have the disease and test positive. When I say 80% sensitivity of CKNB, so you're telling me that 80% of the cases we're going to get people who have heart attack will have high CKNB. If I say ECG, electrocardiogram, has 50% sensitivity for heart attack, what does it mean?
50% of people have heart attack.
40% of people who have heart attack will be positive in the ECG. That's the elevation, right? So 50%, is it high or low? Low, right? We want high. We want sensitive tests to tell us that if this patient has heart attack, it will be positive. When I say specificity, what is specificity on the other hand? It is percentage of people who don't have the disease and who test negative. So it can differentiate between people who have or people who don't have. So when I say a test has 80% specificity, so it tells me that people 80% of the time who don't have the disease will be negative. So which test you want? You want high specific test or high sensitive test? You want them both. The higher the better. It's a balance. This is what we do as a clinical chemist, is to try to balance between sensitivity and specificity. We may have to reduce the sensitivity to improve the specificity. If you can get them all to 100%, wonderful. As simple as this. So these terms I want you to think, every time you read about the test, for instance, gave you an example, ACG 50% sensitivity for heart attacks. At least you understand that it will be positive in 50% of the cases. Okay? So we'll discuss that, and we'll talk about myocardial infarction profiling. Now, enzymes, we know what enzymes. This is just a summary for what you need to know about enzymes in terms of that they are catalysts, that they're mostly proteins. We gave some examples that where RNA could act as an enzyme as well, and we have specificity as well. And in addition, we have specific distribution, meaning that we have isoenzymes. I gave you an example, hexokinase, glucokinase. We said glucokinase is in the liver, right? So, can I utilize glucokinase as an enzyme to diagnose liver damage?
Yes.
I could. Is it useful? Well, no one has looked at it, but this is one way of doing it. So, we do always look into tissue distribution of these enzymes. Now, we utilize these enzymes for diagnostic purposes, and these are intracellular and low concentration. I told you about especially the non-functional enzymes in circulation. We call them non-functional because there is no function for them in the blood. Why are they in the blood? Leakage or proliferation, as simple as this. They're released. That's why they are at low level. If they are increased, then there's a problem. Could it be cancer? Could be. Is there a damaged liver or damaged organ? Could be. So we do have assays to measure these enzymes, and we could tell also the isoenzyme that's present in circulation. We could use it for differential diagnosis. And this is what we call organ specificity. And we're going to discuss this in the heart as an example and in the liver. Now, we do utilize these enzymes for many things, including differential diagnosis of diseases. We already got an excuse before beginning the lecture. That's why I'm allowing, in case people are looking or wondering. We do look into differential diagnosis. We're going to utilize it. As I said, I'm going to show you some examples by which we can tell if this patient has a heart attack or this patient doesn't have a heart attack. We look into what we call differential diagnosis. At the same time, we could follow the disease. I'm going to give you an example for heart attack as an example of utilizing these enzymes for differential diagnosis. The question is, let's say someone had a heart attack. He got into the ICU. After 2 days, so what do you think his profile enzymes? Is it going to increase or decrease?
Increase.
It's going to increase, right? Let's say he got another heart attack. Right? How can we tell?
Double the amount.
No? That's the thing we're going to discuss and show you which marker you could use for reinfarction as an example. Why is it that we need to monitor? If I say that with heart attack we have to monitor the enzymes every 8 hours to see if this patient is responding to treatment, to see if this patient has a heart attack in the first place, meaning that let's say someone is in the hospital and he starts suffering from heart attack. Do you think his enzymes are going to be high? No, they're going to be normal. If I take a sample of this patient, he's normal. So would I take a sample if someone just walked in? No. Yes, I'll use that as a basal line. I want to see what's the increase after 4 hours. Do you see what I'm saying? So you take sample, but you analyze after a few hours to see if this patient has really a heart attack. And then you start the treatment. But would you go right away with streptokinase and urokinase? Each injection is $1,000. Would you go right away? You have to confirm that he has a heart attack. That's why you do the analysis multiple times until you confirm. We're going to look into this profile as well. So, in terms of the isoenzymes, which we said, these basically proteins that are different in structure that catalyze the same reaction. At the same time, they differ in three major ways: in their enzymatic properties, physical properties such as heat stability, and biochemical properties such as amino acid composition and immunological activity. Excuse me. From whom?
That's in council.
Who's doctor?
Dr. Sharif.
Okay, I'll talk to him. So we see biochemical properties such as amino acid composition and immunological activities as well. Now, we do utilize enzymes in three different areas. That includes, which we're going to be talking about mostly, diagnostic, therapeutic, and laboratory testing. We will focus on the diagnostic applications, and we already talked about functional enzymes such as blood clotting factors, non-functional enzymes in plasma such as LDH, CPK, and all what it means. They don't do any function in the blood. And that includes examples LDH and CPK. So if you look into the blood clotting factors, we have the ceruloplasmin, which is the peroxidase enzyme. And usually, in disease condition, do you think that these functional enzyme, disease condition is going to be high or low?
No.
It's going to be low. That's why we have a problem. Wilson's disease. We'll see ceruloplasmin. Increase or decrease? I mean, it says right there, its peroxidase enzymes should be low. So this is why concentration in plasma is high. These are functional enzymes, whereas non-functional enzymes, the concentration is low. And basically, in disease condition, we have decreased level of these functional enzymes, whereas in non-functional enzymes, we have increased levels of these enzymes. But also, it's not only about damage. We said proliferation, cancer. Why is it that we do have low levels of plasma enzymes in circulation? These cells, basically, we do have wear and tear of tissue cells. So there is leakage, there is damage to some cells. As a result, we have release of these enzymes into the circulation. When we have cancer or hyperproliferation, what happens? We have more cells, more wear and tear, as a result, higher levels. So the levels you're going to see is going to be increased. How much? Depends on how much proliferation there is. In cancer, usually cells don't die. So what happens to the levels is going to be less than if it is just proliferative condition. Anyway, the bottom line here, we have two conditions. Either we have damage or we have proliferation resulting from, for example, from cancer. So, enzymes in circulation, plasma enzymes. If they are higher than normal, usually this is a result of increased damage or cell proliferation. If there is less than normal, usually there's reduction in terms of the synthesis, and this is usually resulting from inherited deficiency. And there we introduce what we refer to as inborn errors of metabolism, where there are two basic conditions for enzymes in diseases. The first one, the enzyme is the fundamental cause of the disease. So we have deficiency of that enzyme. We have mutation, genetic changes resulting in deficiency or basically no enzyme activity. This results in what we refer to as inborn errors of metabolism. Another mechanism where the abnormal enzyme activity is a consequence of disease or trauma, cancer, or damage to the tissue. And do you think there's mutation here? No, usually it's in the inborn error of metabolism. So inborn error of metabolism, these are inherited absence or mutation resulting from inherited absence or mutations in enzymes, as I told you. Examples, the urea cycle or glycogen metabolism. These are inborn errors of metabolism. The problem with these deficiencies is that we have accumulation of the substrate or metabolite byproducts of the substrate because of the fact there's no enzyme to metabolize these substrates, such as glycogen. If we don't have an enzyme that metabolizes or degrades glycogen, there is glycogen accumulation. As simple as this. So this is glycogen storage disease as an example. Most inborn errors of metabolism, they manifest after birth. This is what I just told you. We weigh the infant 24 hours, and after a few days, you see that he is fine. Because of the fact they manifest after birth. Why? Because these enzymes usually are present or taken from the mother to the infant. What are the therapeutic strategies? Well, many things. We could change the diet. We could also, enzyme replacement as a therapy. What is enzyme replacement?
Pills.
Dietary intake of enzymes.
So you're saying pills, right? Can you digest proteins?
Yes.
Meaning that can you take an enzyme and just take it? What's going to happen to it?
Add it to the
It's
food.
going to be denatured.
Add it to the food.
Yeah, but we're going to break it down into amino acids, right? So you have to give it as IV or inhalation, right? But IV, talking about lifetime. What are you going to do? In addition, what do you think about immunogenicity of the proteins? When you inject protein into circulation, what are you going to do to it? You're going to produce antibodies, right? So you're going to reject it. So is this a solution? No. The other solution, gene therapy. What happens with gene therapy? Is there a disease now we can treat with gene therapy at this stage?
Cystic fibrosis.
Can we do that? How can we do it?
We change the gene of the person.
Can we change the DNA of the subject at this stage? Yes, we can, but are we allowed to?
No.
We had a few years ago trial with gene therapy using viral particles. The problem, the virus basically got activated, killed a few patients. So they allow it only if it's non-viral based gene therapy, and there's a lot of limitation. Okay? So these people with inborn error metabolism, actually their option is not that much, unfortunately, and could be fatal. Here are just examples. I'm not going to, at this stage, I'm not going to come and ask you about each example. Just want to show you some enzyme deficiencies, which are listed for you here. This enzyme is involved in glycogen storage disease, type 2. You will have a lecture about glycogen storage disease. Another enzyme, lipid storage disease. You will have a lecture about lipid storage disease as well. This enzyme is also the alpha-galactosidase A, lysosomal storage disease. And look at the consequences, just to see what happens in each disease. These you need to know in the long term, but not for this lecture. But you will need to learn about the Pompe disease, which is the glycogen storage disease type 2. And basically it leads to glycogen accumulation in several organs, especially the liver, resulting in congestive heart failure. If you look into the lipid storage disease, the Gaucher disease, accumulation of glucose erythrocytes in several organs, reduced lung and brain function, pain in upper trunk region, seizures, convulsions. For this block course, I'm not going to ask you about it. But for other blocks, you will have all detailed information about these syndromes. But at least now I understand what are these conditions, basically, resulting from enzyme deficiency. Now let's talk about principal diagnostic enzymes. And if you see these enzymes which increase in disease conditions, now we're talking about increase in disease conditions, we do have, notice here we're doing it backward, meaning ALT, alanine aminotransferase, which is the same name as the SGPT, or SGPT, some people call it. It's the same enzyme. Usually we utilize it for liver diseases. So I'm just giving you some main enzymes which increase that you're gonna, almost all the differential diagnostic decisions, you're gonna be looking at ALT, AST. These are the most common enzymes you're gonna be ordering. ALT, then you have the aspartate aminotransferase AST, or the SGOT or SGOT. This is the old name. Most people utilize the AST. This is for liver disease. However, it will be increase in myocardial function, so it's not specific. Is the ALT specific?
Yes.
No, because it's going to be also altered in other conditions. Thus, what do? We utilize multiple enzymes by elimination. So if I see ALT, AST are both high, most likely that's liver. ALT is more specific to the liver than the AST. Now, if you look into the CK or CPK, creatine phosphokinase or creatine kinase, it increases in myocardial infarction, muscle disorders, crush injuries. If you have an accident, if you play soccer right now or exercise, come, let me draw your blood. CK is going to be really high. Does this mean you had a heart attack? No, because of the fact that it increases anytime there is muscle involvement, damage, and so on, exercise, muscle disorders, crush injuries, it's not specific. So how can we make it specific to the heart? That we will discuss in a few minutes. We have the LDH, lactate dehydrogenase, which is also increase in muscular dystrophy, in MI, liver conditions. I can give you a host of conditions the LDH is going to be high. So how can I utilize it? More enzymes, alk phosphatase. Usually you order the alk phosphatase if you have obstructive jaundice, you suspect obstructive jaundice and bone disorders, but also it increases in liver diseases as well. You look into acid phosphatase. You need to know these enzymes. I'm not going to ask you about the normal level. Usually we give you the normal levels, but know the major enzymes. Know the major enzymes, because you're going to see these enzymes over and over in every block, that we use this enzyme for diagnosis or that enzyme for differential diagnosis and so on. You have the amylase, acute pancreatitis or mumps. Lipase increases in acute pancreatitis. We have gamma-glutamyl transpeptidase or gamma-glutamyl transferase. This is in liver diseases, and mostly it's used for detection of chronic alcoholism, but also it is involved if you want to see if someone is alcoholic or chronic alcohol intake will increase gamma-glutamyl transferase. So what do we use it for? Basically, if you want to know what's the cause of the damage, but also how high it is. Is it intermediate high? Is it very high? What's going on? And this is how we could use it. For US, no one cares except unless you have liver disease, but also if someone is buying, for instance, a policy, life insurance policy for $1 million, the company wants to see if this guy drinks alcohol heavily. Because if he does, the company is not going to sell it to him. Why? Because he's at high risk of getting into accidents and so on. So they usually request this enzyme to see if he's a heavy drinker or not. Okay? So the last one, which is enzymes which decrease in disease conditions, example the serum peroxidase, and this is in Wilson's disease. Now, we're going to do it backward, meaning we take an organ and see which enzyme we could use to diagnose any condition in that enzyme. But profiles not only contain enzymes, it could contain proteins. I'm not going to cover these proteins. Example, myocardial infarction. You have CPK2. Notice here, we just added 2, or CKMB. What's the difference? Just wait a couple of minutes, we'll explain that. You have AST, LDH1, isoenzyme. But also, if you're going to diagnose heart attack, you don't rely on these enzymes. These are actually part of the old school, except the CKMB. So what do you rely on? Proteins, such as myoglobin. Where is myoglobin present? Muscle. If there's damage to the muscle, it's going to increase, right? But is it specific?
No.
It's not specific, because when we say if you exercise, you will have the myoglobin high. But why do we use it? Because it increases
Diagnosis.
faster. Within 2 hours, it starts to increase. So it's sensitive, but it's not specific. You see what I'm saying? We're going to look at the profile in a minute. So another protein, troponin I or troponin T, you're going to hear a lot about it. You know already about troponin? It's muscle proteins, right?
Yeah.
But the troponin I, troponin T is high in the heart, right? If you ask cardiologists, they say, it is not a myocardial infarction unless troponin I is increased. Why? Is it specific or sensitive?
Sensitive.
Troponin I. Specific. This is what I just said. Cardiologists say it's not a heart attack unless troponin I is increased. Because they know it's specific. So now you need to know to differentiate between sensitivity and specificity of a test. We will be taking a lab after what you're doing right now in terms of the PCR RFLP. We will be doing HIV detection by ELISA and HIV detection by Western blots. Why do we do that? ELISA.
To avoid false positive.
False positive. If I tell you 20% of tests in ELISA, using ELISA, HIV ELISA, 20% is false positive. So, how do you confirm it? With the Western. The same concept. We use here multiple enzymes to do so. So let's look into liver disease. We have ALT, AST, ALP-FOS, and I told you that it's increased in obstructive jaundice, gamma-glutamine transferase, and LDH5, which is also increased in liver disease. As I said, this is not the only ones or analyze that we use in the panels. If I tell you albumin, we add it to the liver disease panel. Why?
Because it's a blood protein.
Blood protein synthesized by which organ? Liver. So it tells us about the synthetic capacity of the liver. So if albumin is low, the liver is not functioning. Why can't I use these only enzymes? When do you think these enzymes are usually, what do you think about these enzymes? Are they going to increase only in acute or in acute chronic?
Both.
These come from what? Damage, right? If the liver is damaged severely, and after a few days, all these enzymes are already cleared from circulation, do you think the liver is going to be high?
Yes.
No, it's going to go down. Because the damage already occurred to the liver, most of the cells already damaged, leaked into circulation, cleared by the kidney, it's no longer in circulation. And this is what happens with acute myocardial infarction. We have different proteins that get cleared after 2 days, after 7 days, after 10 days. So this is what we use. The whole idea, just want to give you a general idea about the enzyme utilization as diagnostic tools. If you look into muscle disorders, CK3. Why CK3? Why LDH5? In a minute I'll tell you why. AST. Bone diseases. We look into alkaline phosphatase. Pancreatic disease. We have alpha amylase. So, let's talk about isoenzymes. This is your last chance. Okay?